Yeah, thank you. Just from me to the organizers for inviting me. It's my first time in Qatar, and we are sport mad in South Africa, and this looks like it's the right place to be if you play sport. All right, so I'm going to cover a bit like it's not going to be too specific, so I think everybody can follow it. And I turned 50 this year, and I thought I'll add a bit of wisdom to it. But after listening to John, he's changed the goalpost again. So I think I have to wait another 15 years before, 10 years before I become wise. So I'm back to where I am. So I think all of this comes from, we all know this. Patients who have previously undergone a meniscectomy are known to potentially suffer subsequent knee problems, including degenerative changes. So this is the philosophy out there. So I just put this in, but I think in the previous, I think Miles showed already all the function of the meniscus, and I just wanted to put this there, then it's not just a spacer, it's not just the absorbing load, it's doing a lot of other stuff, joint stability, all these things, and when we repair them, and when we substitute them, and when we put grafts in, are we really repairing all of these? So sometimes we base all our stuff done in a cadaver study and shows how the forces change after meniscectomy, but that's not what it does. We mustn't oversimplify things. So what to do? So we all of us say it as much as you can, either by suturing it or substituting it or replacing. Perhaps I can just stop there and then we can have some more lunch, but it's not as easy as that. So what is the evidence for repair? We already know the Annandale. We have a different number, I think 85 or so, but these shoots, look at this, more than 100 years ago. First sutured the meniscus, degeneration. King showed in 1936 that there's degeneration after meniscectomy. In the 1950s and 60s, the meniscus seemed to be not worth anything and taken out, and you know the problems from that. And then in the 80s, the arthroscope arrived, and we could see it, and now we can suture all of it. I just want to give you a little bit of caution. So this is there's quite a few studies out there that shows that extended follow-up studies have indicated that certain patients, the natural history of the knee after partial meniscectomy might not necessarily be associated with a poor prognosis, and could in fact be quite benign compared with the total meniscectomy. So I think we all know a lot of us do meniscectomies and we do partial meniscectomies. Don't leave this audience and think if you touch the meniscus your knee is doomed to failure. It's not so easy. So repair, I'm going to quickly go through this. Many techniques, we covered this already. I think what's really important is to correct other pathology. So if you have a meniscal tear, you have to think, why did this meniscus fail? And you have to do ACL or alignment. We've seen that all of this is important. All right, so now we come to the results. So there's lots of studies show long-term results of meniscal repair, the incidence of healing and arthroscopic. But what was strange to me, that all the results from meniscal repair give the results of does the repair, is it still there? Does the repair work? But the results doesn't show us that we stop osteoarthritis. But if we do the meniscectomy, the results are showing us we're getting osteoarthritis. And the problem is there's not one level 1 study. There's no study where you had a meniscal tear and you randomize them early. You say, this guy I'm going to repair, this guy I'm going to take out, exactly the same meniscal tear, and then see how you do. So we have to be careful to say that if we do, are we really altering what we really want to do? We know that some of them are bad. Some of the meniscectomies are bad, and the total meniscectomies are bad, but even some of the total meniscectomies I see patients are not so bad. And I think our study designs have been bad. Our study designs is to show that what we do is still there. So I think we need more studies to show really which are the bad ones, which one we should really repair, and perhaps it's something else and not just the meniscus. And I'm going to come back to that. All right, so if we can't repair them, substitute. And a lot of work is done by the Steadman Group and by Bill Rodkey. This is a CMI, the collagen meniscal implant. And they've done very nice studies to show that this really get well integrated, that the force is better, that these things they really work inside the knee. The problem is when they had FDA approval, they had to do a study where they had to randomize them. And they couldn't show 2, 3 years down the line, they had no significant difference between meniscectomy and the CMI transplant. And Noble Rocky very well, and the problem was that they said, they looked at meniscectomies, and meniscectomies, they said, did well for 4 years. So after you do a partial meniscectomy, they do well for 4 years, and at 4 to 5 years time, they fall off, and they start doing badly. And their theory is that if you put the CMI in, at 4 or 5 years time, they will not fall off, they will still keep doing well. But they're not there yet, they haven't proven it yet. So I think that's the problem with all of these, we don't know. And somebody asked me before, how do these work? And the problem with them are that they really work in the ones that are asymptomatic, that have lost some of the meniscus. You want to put it back in them, but none of those patients want surgery. So by the time they are painful and they have symptomatic osteoarthritis, then to go and do this, I don't know, I think the jury is still out there, but perhaps it's too late. What about replacement? Meniscal allograft transplant. And this is a very good, and you can look at it with it's a review of the current literature. There was no Cochrane review on this. And even in this meniscal allograft, there are no level 1 and 2 studies to identify. And that's the problem with a lot, as Dr. Berfeld said earlier. You know, we do these things, but we don't really prove what we set out to prove. There's a lot of studies to show that they work, and in the lab, if you put them in, yes, with testing, they change the way that the forces are transmitted, but there are no level 1 or 2 studies. So the 4 types of graft used: fresh frozen, cryopreserved, and freeze dried. So cryopreserved and fresh frozen allograft are deemed the most suitable. So yeah, once you radiate these grafts, that's finished. In South Africa, we had that experience. You completely destroy the collagen, and I think that's so. The quality of the graft is very, very important, and you need fresh frozen. That's really what you need. So I must advocate the use of non-irradiated grafts. I said that already. The best results occur when using bone anchors to fix the graft, although this requires accurate graft position. So I think we heard before that the meniscus works with hoop fibers. And if you don't really anchor this meniscus into the bone, you are compromising the hoop fibers. I followed up some of these patients, and the sizing is very critical. So we all put the meniscus in. If you put it in too small or too big, this knee doesn't like this. So it's not a benign procedure, and I think we just have to be a little bit careful. Patients have improved outcome if they have less severe degenerative changes within the knee prior to transplantation. So again, you know, who's going to have this big operation if you don't really have symptoms? If you say to your patient, listen, in 5 years' time you're going to develop osteoarthritis, I think if you can tell him 100%, I think those are the times to do. But because of the study designs that we've had before, we cannot really tell our patients which ones are going to do well, which ones are not going to do well. I have one classical patient that is he had an ACL injury, bucket handle meniscal tear, and a chondral lesion. And he got it from running the Great Wall of China, 5,000 kilometers. He fell down some steep, and I said, well, that's unlucky. Well, what do you want to do now? He said, no, he wants to run the coastline of South Africa. They ran a marathon every day for 90 days in a row. Yeah. I did an ACL on him. I did a Stedman microfracture, and I removed most of his medial meniscus. When I presented the case to Dr. Stedman and Dr. Rudke, they said, well, that guy will never run again. As they were talking, he was running past the 3,000 kilometer mark. So again, I don't know, we do not know which ones will do well, which ones will do badly, because I think bad design of our studies. Yes, some of them do badly, but not all of them. And it doesn't give us a license to go and repair everything, to go and put these expensive grafts into everything. I think these are specialized units that have to do them. And really the message is that we don't know. So, no statistical significant studies looking at the isolated medial meniscus transplant have been found. The evidence suggests that the meniscal allograft transplantation provides improvement of pain and function in the short and intermediate time. I think that's one thing we can tell our patients. If you do an allograft, symptomatically they do get better. But also just in the short term. The effort of future joint degeneration is still unknown. The ideal patient in this group includes patients less than 40 years of age with knee pain, proven meniscal injury, and a normally aligned, stable joint with severe degenerative changes. Not many of those patients will have a big surgery. So in knees without surgery, meniscal damage is a potent risk. So this is one of the studies that really tell us a little bit what happens to meniscal injury. It's by Martin England and the meniscal tears. And really what he did was he went to look at asymptomatic patients, did MRI scans and saw who had meniscal injuries and who did not have meniscal injuries. And then he followed them up for 3 years and he found out that meniscal injuries is a risk factor for developing degenerative arthritis. But these guys, none of them had surgery. So really what he wanted to say is the meniscal tear already a part of this degeneration? Have you already got osteoarthritis? And if you operate on them or not operate on them, they're going to do probably not so well anyway. I think one of the previous talks there was to say that if you do a meniscectomy, they do really badly. If you don't do a meniscectomy, they do really well. But nobody does a meniscectomy, already in a meniscus that's not injured. So what we really want to look at, we want to see meniscus injury, treat half of them surgically, half of them conservative, and then see what happens. And perhaps we cannot make much difference. So these results highlight the need for better understanding, prevention, and treatment of meniscal injury. So I think the future, again, we hear it more and more, and the sports docs that are here probably like this slide. Prevention, we have to prevent this injury. But biology and all this, I think there's some promise in the future. We have to understand more. The objective should be to save the meniscus whenever possible and refrain from substantial meniscus restoration. So I think this is good to put this in our registrar's head, that they mustn't just take them out. Meniscal restoration can be expected through comprehensive assessment. So we have to do better studies. We have to understand how the meniscus works better before I can really come up here and tell you exactly what to do. So with that, I thank you, and I invite you to come to Rio de Janeiro next year. Thank you.